Hello, everyone. I'm John Lynn, the founder and chief editor at Healthcare IT Today. We're excited to bring you in our series of interviews with top leaders in healthcare IT. Today's guest is Joe Anstine. He's CEO and co-founder of PriorAuthNow. Welcome, Joe.
Thanks, John. Happy to be here.
Yeah, so PriorOps are the bane of doctors' existence. But anyway, before we dive into that, tell us a little bit about yourself and PriorAuthNow.
Yeah, so my name is Joe Anstine, co-founder and CEO of PriorOuthNow, sort of lifelong entrepreneur, but first foray into healthcare was this company, PriorOuthNow. So we have decided to tackle one of the most complex use cases within healthcare. That's called a prior authorization, which we'll get into more, but at its highest level, prior auth is a very specific type of transaction that provider and payers have to deal with, but has very long tentacles that impacts many aspects of the delivery of care. So we're sort of find ourselves right in the middle, being able to find a way to help doctors and help health plans in a way that ultimately improves patient outcomes. So big mission, big vision, and a lot of folks that we need to coordinate with in order to make our network and ultimately our vision go. So it's been a long and winding journey, but we're making progress and seeing real results, which is exciting.
Yeah, I can imagine. So tell me, how are patients really being impacted for good and bad by prior auths?
Yeah, it's a good question. Oftentimes I will talk to folks and they'll say, I've never heard of prior authorizations. And I said, well, you ever been to the doctor and, you go in and you say your knee hurts and, sort of common practice, they'll take an x-ray and see if something's structurally wrong and, they don't find anything or say, hey, we're going to take a closer look. And so let's go ahead and order an MRI as an example. You ever noticed how when they do that, they hand you a piece of paper and they ask you to go to the front counter and schedule it. And they always schedule you at least a week out. And that is mostly happening because they have to pre-register you. And one of the longest pole in that tent is the prior auth. And so because the prior authorization process is manual and it's completed by an army of people on both sides of the provider side and the payer side, it takes, on average 7 to 10 days, which is why you can't or they won't schedule you before that, because if you don't get the prior auth, then the provider doesn't get paid. And so the way this sort of shows up with patients is it is a major delay to patient care. Oftentimes, an MRI, it's just convenience. You have to go home and wait 7 to 10 days. But as you think about, more, impactful care or more urgent care, having any sort of time delay in there could mean significant adverse effects. So there's also a quality and a danger aspect to delaying proper care. And so we have set out on this journey to really simplify and provide value to both payers and providers in a way that they can coordinate and collaborate on care decisions in a way that does not delay care and certainly accelerates access to proper care.
Yeah. I think it's interesting. I mean, I kind of led off the episode with talking about, the bane of existence of doctors, right? But I think many of them look at it and say, well, what's really stopping this from just automating this prior authorization process? What do you see as the big blocker that's stopping the automation?
Yeah, it's a good question. I think within healthcare is unique in that a lot of the systems that have been built like fortresses that will sometimes lower down a drawbridge. And so we think, from our initial thesis was always the fact that one of the reasons why this hasn't been solved is because you have to create connectivity between health plans and providers. Yeah. And that is easily said, very hard to do in practice, especially when those systems that are being used today weren't built with interoperability in mind. And so, and not to mention, there's, when you think about things that are built under the medical benefit, which are oftentimes those procedures or the injections and the infusions, surgeries, things like that, a lot of times those particular transactions, there are no standards. So there's no sort of common way that a provider or a payer can transmit information and understand what they're trying to tell each other. And so you sort of compound the fact that there are no standards on the medical benefit side with the fact that the systems that we need to connect to weren't built with interoperability in mind. And then you layer on top the fact that the prior authorization is this weird intersection between clinical and financial data. So it's not transactional. So even if there was a standard out there, you can't fit prior auth within a transaction. I always like to say it's not transactional, it's conversational, right?
Interesting.
It's not a binary decision. You don't just send data, they send back a yes or no. It's like this infinite amount of decision trees based on what you send. We'll ask more questions, we'll ask that question, we'll follow up here, well, we need that piece of information. So you need to be able to manage that conversation. So it's connectivity, but not only connectivity, it's the right connectivity to enable all of the back and forth that need to happen in order to land on the appropriate amount of care. And you compound that with the fact that medical evidence is changing. I think I read somewhere that the amount of healthcare data is doubling every 73 days.
Yeah.
And so just the sheer amount of data, the time it takes to understand that data and how it impacts care decisions, you can see why this was a problem in the 90s. The government tried to lean in and fix, and here we are in the early, late to mid 2000s, still this being a problem. So.
Yeah. Seems like, I mean, to your point, there's no standard, but there's also a diversity of systems and players, right? That every doctor has a different EHR and every payer has a different system. And, so that seems like a problem as well, that there's just so much diversity. And let's not even forget about retail healthcare and labs and everyone else, right? I mean, there's just a broad, diverse system that needs to do prior auth as well, right?
It's sort of insane when you think about all the different types of connectivity that you need to make in order to make this work. And so, a lot of early sort of criticism we had was, hey, your platform approach to the market, where you're going and establishing coordinated connectivity on both sides with payers and providers, they would always say, well, that means you have system dependencies. And we would say, yeah, that does. But we don't see any other way than creating those connections for this to go away. I mean, if you look at sort of the current market before we entered it, you had a lot of revenue cycle management platforms out there that did a lot of things, claims, eligibility, other pre-registration activities. And they tried to tackle prior auth, but they did it in a very fragmented or transactional way. They went after the soft tissue and only tried to solve it on one side of the aisle. So oftentimes they would go to providers and they'd say, hey, we might be able to tell you if an auth is required or not. Yeah, that's helpful. We might be able to tell you, if a status changes. Yeah, that is helpful. But they left the meat of the problem at the provider's feet, which is doing the actual submission and the back and forth with the health plan to actually get the decision. And without connecting to those systems, without getting access to that data, structuring that information and making sense of it, this will be another, this problem would have lasted another a century. So there's just no way around it. If you're going to solve it, you need to have the time and the capital to overcome, the impedance that comes along with connecting systems on both the provider and the payer side.
Yeah. So there's a lot of cynical doctors. I think it comes from experience with prior auth, right? Or, that they look at it and they say, are prior auths really just the payers trying to control me as a doctor, right? Or even like, well, I'm the doctor, I should know what's best, right? And then, you could do it from the other side too. Like, why should the payer even want to work on this, right? Aren't they benefiting from denying all these services that they would have to pay for? So talk about that. Is this like a cynical thing where they, the payers are trying to control doctors and trying to screw them out of money? Or, how do you see this?
Yeah, when we first entered the market, there was no doubt that there's this expensive fight going on between providers and payers, and we sort of called it the arms race. And why we described it that way is you have doctors who just want freedom to take care of patients, and they just want to make sure that they can deliver the right care to the patient. However, somebody has to pay for that care. And so on the other side, the health plan saying, hey, wait a minute, we trust you, but we want to make sure certain risk and certain cost constraints are in place to make sure we're making the best decision. And so up until we entered or especially in the early days that we entered the market, that sort of arms race or that expensive fight was really clear. The good news is that some things have really changed where we saw an opportunity where we could enter in and insert a platform and get health plans to lay down their arms, get providers to lay down their arms, and really lean into and collaborate in a way that ultimately benefits the patient. And so a couple of those, I'll call them tailwinds that we got, were first, local care really started to consolidate. And so there's this trend of large health systems buying up independent physician practices. And so what happened is, a lot of the members who prescribe to these plans need care, right? They have to have care. And when you have a high concentration of local care, that means you get sort of this sort of balance of power where, a health plan can't play too many games, or they're going to upset the local care. And if they lose local care, they'll lose members. And so, there was this sort of balancing of power that was happening. But more importantly, new health plans started to emerge and to come into market who realized there was a better way to contain cost than friction. So if you think about prior auth, like how they manage cost or what prior authorization is it's a very sort of a black box process that's very confusing. It's very manual. It's very expensive. And so because of that, there was just a certain percentage of things that just never got submitted, right? And so they sort of use that as a cost containment tool. But other health plans said, hey, there's a diminishing return to that. Because if I make it so complex and so littered with friction, I have to match that on the other side. And so at some point, the costs get so high where, I'm not really saving anything. Yes, we may be preventing, care from happening or improper care from happening, but you're also sometimes eliminating the right care from happening. And it's also costing me a lot of money to manage all this friction that we are causing. And so newer health plans have come in and said, wait, there's a better way. If we can get access to data, create better metrics, have a better understanding of what's happening, we don't need the friction. And we can make sure that we can enable the right care to happen very quickly. And where we need to lean in and have a conversation and collaborate on what the evidence really suggests we can do that in a way that doesn't amass this enormous amount of friction and cause army of people to manage on both sides. So sort of new entrants have put a lot of pressure on some of the more legacy health plans on there has to be a better way. Also, there's been a lot of documentation that has been published around the impacts on patient care. I promise you, in all my discussions with health plans, which been many, not a single one has ever said I unknowingly and sort of specifically trying to prevent patient care. That's not what they're doing. The process of trying to stop improper care sometimes sort of bleeds into that, but they've always been very aware of that and have tried their best to stop it. And so a lot of new, evidence has been surfaced. A lot of new metrics have been surfaced around the impact of prior authorization. And so that's also, ultimately health plans want the best care for their members and they want to make sure they get it in the most accelerated fashion. And so that is another tailwind we caught. And then finally, the government started to pick their head up and say, hey, wait a minute, we're going to start to get in this, that we're all patients at some point. We can't have this current cost containment tool be an impediment to proper care. It's just dangerous and it's irresponsible. And so the government began leaning in and providing different mandates on the types of things that both providers and health plans needed to do in order to make sure that they could deliver proper care in an accelerated fashion. So all those things sort of, combined, I had a conversation with one of the largest health plans in the country just last week, or I'm sorry, a couple of weeks ago, as we were coming into 2022. And I said, hey, what is the can't miss goal of 2022 for you? And they said to improve the provider experience related to prior authorization. 4 years ago, I never would have heard that. And
Yeah.
so now with all of the tailwinds, we're really finding that health plans are motivated. There's a significant amount of willingness. And I think that's always been there. But I think what has changed is a lot of tools have come to market that now enables them to actually act on a lot of those things that they wanted to do, or that vision that they had of sort of a better way to manage cost. And so, I think that, and then prior auth is this, it's unlike any other transaction in that the capabilities you need to eliminate the burden on both sides, a lot of those same capabilities can be reused to help providers and payers collaborate and communicate in a way that enables more at-risk or value-based contracts. And
Yeah.
that's a fancy way of saying you're getting the payer and the provider to both lean in a way that benefits the patient, both in quality and cost. And so I think by tying sort of prior authorization, automation, which automation doesn't go far enough, you need collaboration. By doing that and creating capabilities that prove that we can do that, there is not only sort of operational benefit for the health plans and the providers to lean in, but strategic benefit, and helping them achieve their strategic goals of creating new payment arrangements that ultimately lower the total cost of healthcare and improve the quality and cost of care for patients. And so all of those things in one have really sort of gotten to the point where we're seeing significant amount of interest and engagement on both sides of our network here.
Wow. I mean, that's amazing insight into the various power dynamics and shifting perspective. I know my perspective was rocked a little bit when I was actually playing Frisbee with a group here in Vegas, and one of them's a doctor. She's an ED doctor, but she went to the dark side, as some would say, and was doing prior auths, right? And she was answering those calls from the doctors and saying why they could or couldn't get, whatever they were getting. And she's like, John, I wish you could understand, like, I can fudge a little, right? I can understand some reasoning, but she's like, you should hear the calls that I get. I was like, oh, that's interesting, right? So she's like, there's no evidence for what they were asking. And so I think that's the interesting perspective for me, was like, yeah, sometimes the process probably does stop care that should be happening, right? And because of the dynamics and complications of it, but in other cases it is stopping care that's just not justified. So it's a tough balance for sure.
That's right. Well, that's why when we sort of set out, we knew that whether it was us or somebody else, somebody had to create a platform that allowed for providers and payers to generate value. And you can't take one side or the other. You have to sort of sit in the middle and, quote unquote, be Switzerland, if you will, where you have everybody's best interest in mind, right? We're not trying to create an advantage for providers, and we're not trying to create an advantage for payers. We're trying to get them to collaborate and provide enough value so they continue to collaborate in a way that benefits us as patients. And so that has been the mission, and it has to be the mission if somebody is actually going to solve this problem.
Yeah, you're not Switzerland. You're on the patient side. That's
yeah, exactly. Yeah, that's a fair point.
To some extent, right?
Yeah.
So what would you tell a provider maybe that's struggling with prior authorizations? How can you help them?
Yeah. So what we essentially do is I like to say we've created a platform. But the platform that we have created is solely focused on the prior authorization use case. And what that has allowed us to do is sort of fully model out the process. Prior auth, again, I'm like a broken record here, is unlike any transaction in that it's the 80-20 rule doesn't apply. It's actually inverse. 80% of the time you run into exceptions or dark corners of, well, that's outside the norm. That is the norm, right? The exceptions are the norm. And so you've got to fully model out the transaction to be able to handle all of those edge cases. And so what we have done is we have done that, and we have went to health plans, and we have effectively stood up connectivity with those health plans in a myriad of ways, right? So we have a very hard center, but we have very malleable ends. Okay. And so whether a health plan can communicate with us via, an ANSI 278, 275 from the 90s, whether it's FHIR APIs, whether they've stood up proprietary APIs, however they can communicate with us, we can connect into them. And what we have done is we have taken that connectivity and now we have met that providers where they're at. And so if you're a provider, healthcare for some reason has thought about products differently. Most industries, sort of the golden rule is you must meet providers or you meet your customers where they're at. And in healthcare, it's sort of the inverse. Everybody said, I'll build it, but you have to come to me. And so we have said, hey, we're going to establish that connectivity. We're going to meet the payers where they're at, and we will communicate with them and however they communicate. And then we will take that and we will literally meet the providers where they're at. So what that means is when a doctor is within their EHR, they're not able to jump out to figure out if a prior authorization is required. They're not having to jump out and copy and paste data from one system to another in order to get the required information. They don't even have to click a button to submit the prior auth to the health plan, right? So what we are doing is we are effectively taking all of the administrative steps associated with the prior auth and we're eliminating them. So the way to think of it is about over 99% of the time, we don't ask our providers to enter in a single piece of administrative data. What we then do is, so once we ship that off, so that the provider orders the care, we assemble all the information we need and we ship it to the health plan. And the health plan will come back and say, hey, we need to do a clinical review for this. Well, instead of just going back to the provider and generically saying, please give me clinical, we come back and we're very clear on what we're looking for. But we don't actually go back and ask a human. We will just go in and extract the information directly from the chart ourselves and map it to what the health plan is looking for. And when it matches, we can render a real-time decision or at least an accelerated decision. And so, yes, I'm sure a lot of listeners are like, that sounds really hard, taking unstructured clinical information and mapping it to a payer's guidelines. And they would be right, it is hard. But sort of the genius of what our team has done is it doesn't require perfection. So in the event that we can't either disseminate information from the EHR, we can't map it up directly to the health plan's requirements, we call what we have this on-demand UI, and it shifts from an API workflow to a UI workflow, and that UI is portable. So I can literally ship that UI and alert somebody in the EHR and say, hey, we weren't able to handle this with the machine. I need you to jump in and take over. So think of it like power steering, if you will, for prior auth. And so because we can transition to UI, yes, it is hard to do that perfect every single time, but we don't rely on perfection. So even when we shift to a UI and ask a user on the provider side to jump in, they're still touching a fraction of the time. And so what that accumulates to is once they enter that information in, we go back to then handling it behind the scenes from an API to API perspective without creating any burden. And so at the end of the day, from a provider's perspective, we can meet you in the EHR. We reduce your labor costs by 91%. We reduce additional information requests by 40%. And one of the things that we are most proud of is that we have reduced turnaround times by almost 8 days. And so less burden, more savings, accelerated patient care. And we can do all of that in the systems you're using today. We're not going to ask you to jump out and come to us.
I mean, it's so compelling to think about it happening. And I imagine over time, you're going to get better, right? Like
Bingo.
One that failed and you have to ask for request. Yep. Well, I mean, in many ways, you're educating the provider. You should have put that in the note and we could have just gotten it, right?
Yes.
I've seen that on the billing side for a long time. That same principle. Is that the future path for PriorOps? Like, and where are we at? Like, how often do you have to go back and do that kind of manual additional information versus automated?
Yeah, look, clinical automation, what we like to call clinical intelligence, it is very hard. The good news is there's a lot of new technology that is already in market and a lot of new technology that's being created even by us to really get better at that. And so one of the things that we have done is we have proactively looked for strategic partners in the space who effectively opened up their EHR access to data, access to workflows, most importantly, access to their subject matter experts to help us improve that over time. And so you're exactly right in that every single day we get better and better at making that end-to-end process that includes taking information from the EHR, structuring it, and mapping it up to a payer specific guidelines to the point where you can, at a minimum, accelerate decision making, and at a maximum, automate the decision. Every day we get better and better and better at that. And so that's why we like to say, there's a bunch of people in the market that talk about prior authorization automation. And I alluded to this earlier in the conversation. That just doesn't go far enough. This is not about taking something and pushing it behind the scenes and trying to make it transactional. This is not transactional. It is conversational. And so what we have coined is said prior auth automation is not enough. You need something more to handle the conversation, which we call intelligent collaboration. And what that does is yes, it eliminates and automates a lot of the manual sort of robotic tasks that we're asking humans to do. And we have sort of eliminated those things. But oftentimes there are meaningful interactions that need to take place between a provider and a payer. And so what we have done is we were saying, hey, it's not just about automating it. You have to allow this intelligent collaboration because these interactions are necessary to make sure that providers and payers can collaborate on a way to make sure that every single time that patient gets the best possible care. And so that's really where we see this market going, which is prior authorizations is something that we think ultimately, we can replace with more, with more intelligent collaboration capabilities that really allow them to collaborate in a way that will a high percentage of the time improve the speed and the quality and the outcomes of patient care.
Well, I think someone that's watching this while sitting on hold, waiting for a prior auth, or that's sending a fax of a prior auth, is going to be jealous of the process. But thanks so much for sharing insight into just a really challenging problem that we all want fixed. So thanks so much, Joe, for taking part, and thanks everyone for watching. If you want to find more great healthcare IT content like this, be sure to check it out at healthcareittoday.com, and also search for healthcareittoday.com on your favorite podcasting platforms. Thanks so much, Joe.
Thanks, John. Had a good time. Take care.